All right, today we are building the definitive pharmacist's playbook for one of the most common and, frankly, one of the most alarming calls you're ever going to get. A parent trying to describe pediatric croup. Let's get you ready.
So picture this. It's late, the pharmacy is finally quiet, and then the phone rings. On the other end is a panicked parent. Their child woke up with this terrifying, loud cough they have never, ever heard before. This is that moment. This is where your expertise is absolutely crucial.
And yep, this is almost always how they're going to describe it, that classic, unmistakable, seal-like barking a cough. It's the hallmark sign, and it's our first big clue that we know what we're dealing with.
So clinically, we know this thing as laryngotracheobronchitis. But let's be real, to a parent, it is just a terrifying cough. Our job starts right here by demystifying it for them. You can explain that it's a viral inflammation of the upper airway, and you know what? Well, it sounds really scary. It's incredibly common. Think of these characteristics as your predictive model. When late fall and early winter roll around, you should be anticipating these calls, especially for kids in that 6-month to 3-year-old range. But the most critical point on this slide, the one that really empowers us, over 60% of cases are mild. That fact alone puts us in a powerful triage position to help parents manage this at home and prevent a lot of unnecessary emergency visits. So the first thing we have to do, our number one responsibility, is a quick differential diagnosis. Before you offer any advice at all, we need to rapidly assess the situation to make sure we're actually dealing with uncomplicated croup and not something much more serious. This table right here, this is your rapid mental checklist. Croup has that bark, and it's always worse at night. But you've got to watch for the red flags. If a parent describes a child who looks toxic, has a high fever, and a productive cough, you should be thinking about bacterial tracheitis, and the absolute can't-miss emergency is epiglottitis. The child is leaning forward, they're drooling, and critically, there is no barking cough. If you hear that clinical picture, your only advice is an immediate trip to the ER. Period. Okay, so you've gone through your mental checklist, you've ruled out the really scary stuff, and you're feeling confident this is mild croup. So what's the immediate, evidence-based advice you can give that parent right there on the phone? The number one non-pharmacologic intervention is just keeping the child calm. Crying and getting agitated actually worsen that airway obstruction because it increases their oxygen demand. So reassuring the parent is step one. Step two, suggest they bundle up the child and just stand by an open window or a freezer for a few minutes. That cool air can provide some real short-term relief. And here's where we can correct some common misinformation. The whole steamy bathroom thing, or mist tents, that's outdated advice. There's no good evidence they help, and honestly, the process can just agitate the kid and make things worse. All right, let's get to our core business, the medications. The evidence here is really strong, and it has completely changed how we manage croup, leading to way fewer hospitalizations. If you take only one thing away about treating croup, let it be this. A single dose of a corticosteroid is beneficial for every child with croup. I'm talking from the mildest case you'll manage over the phone to the most severe case in the ER. They flat out work. They reduce the inflammation, and they shorten how long the symptoms last. And here is probably the most critical counseling point you can give a parent. You have to manage their expectations. Tell them clearly, the steroids will take 2 to 3 hours to really start working. Communicating this is so vital because it can prevent that panicked, premature trip back to the hospital when the medicine doesn't work instantly. Our go-to is almost always oral dexamethasone. It's super effective, and giving 1 dose of liquid is way less distressing for a little kid. You'll see doses from 0.15 up to 0.6 milligrams per kilogram. The evidence supports that whole range, but 0.6 is probably the most common. Now, nebulized budesonide is a great alternative, but it's usually reserved for the hospital or if a child is actively vomiting and can't keep anything down. When you're counseling, you can confidently reassure parents that with a single dose, the risk of side effects is really low. They might notice the child is a bit irritable or suddenly hungry, but that's about it. Now let's talk about the other major player, nebulized epinephrine. Think of this as a rescue therapy. This is not for mild croup that's being managed at home. This is an emergency department tool for kids who are in moderate to severe distress, specifically kids who have that audible, high-pitched noise, the stridor, even when they're just resting. See? Epinephrine works fast. That's why it's a rescue drug. It reduces airway swelling within about 10 minutes. But, and this is a huge but, the effects are temporary. They wear off within about 2 hours. This is exactly why any child who gets epinephrine has to be observed for at least 2 to 3 hours afterwards. We have to make sure their symptoms don't return to a dangerous level once that medicine wears off.
So, this whole idea that the effects wear off leads to a really common clinical question, and honestly, a persistent medical myth. What about the so called rebound effect? Let's be crystal clear on this. The rebound effect is a myth. The evidence is overwhelming. Patients do not get worse than they were before the treatment. Their symptoms just return to baseline as the drug wears off, and by that time, hopefully the corticosteroids are starting to kick in. This is a powerful, evidence-based fact you can use to reassure anyone who asks. All right, let's bring it all together. This is your final play. These are the key counseling points that are going to empower parents and make sure that kid has the best possible outcome.
A huge part of our job is often telling people what not to use, because you know they're going to ask. Over-the-counter cough and cold meds? Nope. They're not indicated for kids under 6, and they don't treat the underlying problem. Beta-2 agonists like salbutamol? They don't work either. They target smooth muscle in the lower airways, and croup is an upper airway problem. And since croup is viral, antibiotics, of course, have no role at all.
And here it is, your take-home checklist for parents. First, set their expectations. The worst is usually over in 48 hours, and nights will be tougher than the days. Reinforce that keeping their child calm isn't just nice, it's therapeutic. Reassure them that one dose of dexamethasone is usually all it takes. And finally, give them clear, simple signs to watch for that mean it's time to seek immediate medical attention. Stridor when the child is resting, or any sign that their breathing is getting harder or they're becoming overly tired. And really, that's the bottom line. Croup sounds terrifying to parents, but when you're armed with this playbook, you can be that calm, evidence-based guide they need. By confidently assessing the situation, recommending the right supportive care, and explaining the proven treatments, you are playing such a critical role in providing reassurance, preventing needless ER visits, and ensuring that kids are managed safely and effectively right at home.